take a look at etiology of nephrogenic diabetes insipidus. The most common causes of ADH resistance, severe enough to produce polyuria, are in the following situations. Stop there and take a look at polyuria. As soon as you hear polyuria, you should be thinking about three major mutations. The three major differentials, and the mutations that we'll talk about are upcoming, but the differentials include diabetes insipidus, number 2, diabetes mellitus, and number 3, psychogenic polydipsia. Psychogenic polydipsia, what does that mean? I don't care if you're sick in the head and the voices in your head are telling you to kill me. Well, that's great. The problem is up in the brain, but not in the kidney. So even if you're drinking too much, are you going to produce dilute urine? Yes, you are. So therefore, polyuria, three major differentials, they include diabetes insipidus, diabetes mellitus, and psychogenic polydipsia. Now, how to differentiate easily between mellitus and insipidus? Glucose, right? If you find hyperglycemia, what's your diagnosis of polyuria? Diabetes mellitus. If you don't find hyperglycemia, you have effectively ruled out diabetes mellitus, and now you're left with two other causes. Now, we'll talk about further differentials and management in terms of tests such as water deprivation, so on and so forth, as we continue through the lectures. But at this point, let's take a look at some important mutations that are occurring within the receptors of the kidney in which your ADH isn't working properly. So here we have a following. Here's X-linked mutation, and what you must keep in mind is we have arginine vasopressin receptor, AVPR2 gene. You must know at some point in time in your medical journey, you will be asked about the amino acid arginine. You should already know the other name for ADH, which is vasopressin. You should next know, well, what is the name of the receptor that you have in the kidney? There are two kidneys, hence V2 receptors. Welcome to arginine vasopressin receptor 2 gene. Memorize that. X-linked recessive. Now, there is another one with AR, autosomal recessive or autosomal dominant mutation of an aquaporin 2 gene. And in these instances, what's happening? It's the fact that your receptors aren't functioning properly, and thus your ADH is quite high, and you produce polyuria. Now, clinical differentiation by lack of release. There's an important concept here. You should remember that vasopressin also works in your blood vessel. That receptor is a V1 receptor, isn't it? Responsible for vasoconstriction. In addition to that, there's every possibility that at some point in time, you might want to give vasopressin so that you are then causing the release of von Willebrand factor or factor 8 to deal with certain issues, including your von Willebrand disease, or maybe even perhaps something like hemophilia A. Do you remember this? Vasopressin. Okay, now, say that the gene for the receptors for vasopressin aren't working properly. Are you going to be effectively releasing von Willebrand factor and factor 8? No, you will not. Read the statement. Clinically, differentiation by lack of release of von Willebrand factor and factor 8 from the endothelial cells because the receptors have now become mutated. Keep that in mind. Do not forget that. At some point in time, once again, I am going to refer to this little discussion. Adults, chronic lithium, big time. Let's talk about this. Lithium. Well, who's your patient? Oh, sometimes I'm feeling crazy and I feel like I can conquer the world. You have ideas, grandiose ideas, huh? And other times, you just want to go back home and go hide in a closet and not talk to anyone and maybe perhaps have suicidal ideation. All right, so we talk about bipolarism. So chronic lithium is what the patient is taking. When lithium is taken, please understand that this is not referring to the management in your brain of bipolarism. However, as far as the kidney is concerned, that says ENaC. It's important that you know what that is. E is epithelial. Before I begin, I want you to go to the collecting duct in the nephron in your head. Can you conceptualize? Are you there with me? That collecting duct on the side of the apical luminal membrane facing the urine is the epithelial side, or it's an epithelial cell. It has a sodium channel on the apical side. That's called epithelial Na sodium channel, ENaC. This is how lithium is then going to replace the sodium in that channel. Lithium is then going to enter the tubular epithelial cell. Okay? Now what? You're worried about what? You're worried about nephrotoxicity. You might be worried about a patient developing diabetes insipidus. What kind? Nephrogenic. The problem is this. What's on the basolateral membrane? The basolateral membrane has a sodium-potassium pump. So why can't you get rid of the lithium? Dr. Raj, if you're telling me that lithium replaces the sodium in that sodium channel, then why doesn't the lithium replace the sodium to then work through the sodium-potassium pump to get out of the cell? I don't know. It doesn't, okay? I'm sorry. I really am. It's all my fault, and lithium doesn't get onto the pump. And no, I don't know why. I really don't. But what I do know, and what you should know, is that lithium will not replace the sodium on that sodium-potassium pump. Thus, where is your lithium now accumulating? In your renal tubular epithelial cell. Are you then bringing about nephrotoxicity? Yes, you are. Are the receptors working properly? No, they're not. What would be a drug-induced cause of nephrogenic diabetes insipidus? Chronic lithium use. Let's continue. Now, let's talk about ADH and its effect on your cell. Let me set this picture up for you. This is the principal cell. Where are you? You're down in the collecting duct. You have the lumen, and that would be the urine. Clear? The lumen that you're seeing on the left is the urine. On the other side of the cell is the blood, and that's your interstitium. Now we're going to walk through the course of ADH and how it works, and a couple important things that you have to know here, because you will be asked questions about how this mechanism works through its second messenger. Okay, ADH binds to its receptor. What's the name of this receptor? V2 receptor. What is at least one gene mutation that you want to know? That's called arginine vasopressin AVP receptor 2 mutation, X-sync recessive. Once ADH binds to the receptor, how does it work through? Now, this is for biochemistry. GS. That GS is AAAA. Adenocyclase takes the ATP, turns it into cyclic AMP. Cyclic AMP, protein kinase A, bring about phosphorylation. What kind of aquaporin? AQP stands for aquaporin 2, being inserted where? On the luminal membrane, so then you can reabsorb that water. Now, a couple important things. You see this GS, and you see that cyclic AMP? That's important because I'm going to give you a mighty tasty piece of information here that you're just going to eat up. It's about bypassing this receptor and seeing as to whether or not you can work through, what is it called that breaks down cyclic AMP? Phosphodiesterase. So in the receptor area, what if you inhibit phosphodiesterase? Increase cyclic AMP? Is it possible? Is it just possible that there's enough research out there, and you might get a question where it says, wow, my patient has nephrogenic diabetes insipidus, number 1, where you see this as being number 1, that's the pathology on the blood side. But what if you're able to bypass the receptor? What might you want to give? How about inhibition of phosphodiesterase? You've seen that before. That concept was also used in cardiology pharmacology as well. Let's continue. In the presence of ADH, we know that aquaporins are put in. What kind are they? Type 2. Once they're put in, then you allow for water to be reabsorbed, make it more permeable. Now, in pharm, take a look at the top here. You can bypass that receptor. You can bypass the receptor with a prostaglandin E2 receptor. And the reason that I say that is because, well, prostaglandin E2, and you should remember this is lovely physiology that is then now being derived, and this is how you want to think. Remember, my job is to give you as many angles as possible for a possible question that is thrown at you. And if you don't understand the fundamentals, then things become a little complicated and maybe downright impossible. That is not going to happen between you and I. So a prostaglandin E2 receptor may then stimulate. You see where it says number 2? That number 2, as long as you're able to stimulate that adenocyclase and you bypass the receptor, because what's my disease? Nephrogenic diabetes insipidus, then you have created the signal transduction pathway moving forward in which you can then insert the aquaporin and perhaps manage effectively your patient with diabetes insipidus nephrogenic type. Beautiful, isn't it? I would think so. Keep that in mind. Research, those of you that are interested in pursuing your PhD after your medicine, plenty of room out there, plenty of room. But this is a relevant topic that is hot, and so therefore is quite relevant, what you need to know at this juncture.